Hello everybody, Namaskaram. I'm Dr. Sivasankar Dalai, Chief of Neurovascular Intervention from Visakhapatnam Medical Hospital. We are going to show you a live carotid angioplasty. This is basically the patient who is a middle-aged patient who is having a repeated transient ischemic attack, that is like a mini stroke. And we investigate the patient, found that there is a critical stenosis of the left carotid artery. We are going to do angioplasty and stenting of the right carotid artery with distal embolic protection. So, that's it.
Sir,
We can brief about, yeah.
Sir, so we'll start with the question, sir.
Yeah.
Typically, what is the duration of this procedure, sir?
Typically to do a carotid artery stenting, we take about 30 to 45 minutes, which is done under local anesthesia. So what are the evidences of carotid recanalization by stenting and surgery? Arvind,
Sir.
please brief us about the evidences.
So actually, there have been numerous trials conducted with regards to carotid recanalization, and the two most commonly used techniques were carotid endarterectomy and carotid artery stenting. So previously, before endovascular therapy has progressed considerably, carotid endarterectomy was considered the gold standard. But however, with the recent advances in endovascular technology, now the later studies have indicated a non-inferiority of carotid artery stenting when compared to carotid endarterectomy. And anecdotally, in our center experience, we almost exclusively always prefer carotid artery stenting, and we have observed some fabulous results, close to 99.999.
All right, so we will see the distal embolic protection. Here we have chosen a NAV6. So this is the filter, and we just have taken lots of normal saline because we just want to take the air out of this filter. And once that is done, then we take the filter inside till the golden mark touch the black mark. We will show you once we take this device out. So this is the NAV6, the distal embolic protection, which will go inside. We give a little shape to the wire so that we are more comfortable when we are navigating it further. Yeah. So gentle J. So in the team with me, helping me out, and then we have Dr. Arvind, who is giving us all academic support here, and we have Murli, who is the chief cath lab technician, and Gauri, who is assistant nursing. Just give me a mag. The screen is visible. Maybe a roadmap. So you can see it's a very, very critical stenosis. If I just go to what I just said. Show me the previous one. Yeah, the same here. So we can see the very critical stenosis of the internal carotid artery. We will try to navigate. Can I have a screen to also prove for start? All right. So this can be said as a 99% stenosis, very thin. We have taken our distal embolic protection, and we should have sufficient distance between the distal embolic protection and so we will deploy the distal embolic protection, which is an umbrella-like device. So when we are doing the carotid artery stenting, in case some clot migrates, this will be caught by the distal embolic protection, and finally at the end of the procedure we bring it up.
So in some of the older studies where they have compared the carotid endarterectomy with carotid artery stenting, in most of the major trials, the earlier major trials, they have not used any embolic protection device. Now, if you are watching carefully, you can see the embolic protection device is an umbrella shaped device.
We can
which
give a
prevents-
map. We can show this is the umbrella. We can see the distal embolic protection here. Very beautifully seen. This is the umbrella, and this is the area where we are going to do the intervention, the critical stenosis. When we are doing an angioplasty or stenting of this area, if there's a clot going, this is the distal embolic protection which will catch the clot. Take out the road map.
So with the advent of this embolic protection device, the results have been extremely favorable for carotid artery stenting.
And particularly me and my team, we have done over 1,000 carotid artery stents in the last 10 years. This is a very, very routine procedure for us in the department. Give me a balloon, 5 minutes. 10 please. So we are very much in control. Can you give atropine 1 and 2 lines? Yeah. So you can see this. This is the common carotid artery. Can you stop this, Prashant? Yeah. This is the common carotid artery. This is the external carotid artery. This is the internal carotid artery, and the proximal part of the internal carotid artery, which is having a very critical narrowing. We have put a distal embolic protection so that we can do a So we are giving 1 ampule of atropine here because as we do our yes please. Keep a little away in the right track. 520, yes please. Here it is. Here down. So it's very, very important for us to have a very stable space, very stable access into the common carotid, and the next time we can show you a transradial carotid angioplasty, which has become a norm now for us. So you can, don't move. Kadalazu. Put back out today. So we are doing a little bit of inflation. Yeah, please. Right. Okay. So we are giving a gentle inflation over here. Inflate. So you don't have to keep inflating for a long time here. You just have to have a quick once more. Stop. Deflate. So now we have seen, we have done a balloon angioplasty of the disease segment. Then we deflate and bring it back. So after the angioplasty we will see. So this is the angiogram before the angioplasty. This is the angiogram, and now looks better. Looks much better.
Sir, how much would you rate the stenosis to be, sir, post angioplasty alone?
Just angioplasty we have done. Now I will say that it's having 60% stenosis.
Prior to that, it was how much, sir?
It was about 98 to 99%, over 95% at least. Can I have one? Exact. So we will take a stent, which will be a self-expandable stent, which will be inserted, and we will ensure that the stent is placed across the disease segment. That means it goes from the normal distal to the normal proximal. Yeah.
Do all the patients with such critical stenosis require stenting, sir?
Sorry?
Do all the patients with such critical stenosis require stenting?
Yes, yes, yes.
Have you done any cases where only angioplasty alone suffices?
No, I'm not right. Because the evidences always say that angioplasty alone is not enough for carotid artery disease. You must have enough stent. So she's quite an experienced assistant. She has done over at least 600 or 700 cases with me. Before Matthew. So we've navigated the stent. This is a 6840 stent, exact self-expandable stent. And we always push it a little bit and then pull so that there is no lag when you are deployed. And meanwhile, I will have to just pull my guiding lever. How long to take? How long to? So we'll do a shoot before we do a check angiograph. So it looks perfectly okay for us. And now I will go ahead and deploy. You can see the screen up. The stent is opening in the screen number 2 on the upper area. It's deployed beautifully across the lesion as we have planned. Roadmap up. Out. So we will do an angiogram and then decide the further course of action. Halan to niya kaya, halan to. Alright. So Arvind, do you have any questions?
So the atropine which you have given, sir, prior to the angioplasty,
Yes.
can you explain the exact rationale why we give it?
Because you have a carotid body over there, you're doing an angioplasty, and once there is massage of the carotid body, the BP might drop, the heart rate might go down, so
Sir.
it's just a preventive measure. Sometimes you see that there is very critical carotid stenosis, and you did a stenting that could be prolonged hypotension for about 24 to 48 hours.
So is there a chance, sir, that patients with borderline hypertension may be weaned off medication at least temporarily for the first few days?
Yeah, that is what happens generally. But generally what happens when we do a carotid stent, the BP drops. So we stop the antihypertensives in those patients, and then we titrate them as the time progresses, so it can settle down. Then you can restart. And in some patients you don't have to restart antihypertensive also for quite some time.
And what is the life expectancy for the stent, sir?
Generally, very rarely we see occlusion of a carotid stent. I have seen one in my life. So I'm talking about, I'm doing carotid stent since 2006. Go ahead. So we generally don't see, and in literature also the patency of the stents have been mentioned as very, very good. Excellent patency. One more. Stop, reflect. Yes. So your idea should be to get up to 80% of the lumen.
So why do we avoid 100% patency re-establishment, sir?
We generally don't go beyond 80 to 90% because you can actually rupture the vessel, you can dissect the end of the stent, all those things are possible, but 80 to 90% is good. So now we will see the carotid circulation and cerebral circulation. If everything looks okay, then we will try to capture the nerve cells.
Sir, are there any chance of migration of the stent after implantation?
No. After complete implantation is done. Unless you made it like a very small size. Those things are also. Let's look at the cerebral circulation now. Can you please? Go back, get up. It's very important to keep watching the cerebral circulation because you might have a stroke or looks beautiful.
Sir, on a hypothetical basis, if
If
suppose
yeah,
the patient develops a stroke,
yes.
what do we do now, sir?
You do a stroke thrombectomy. You have a patient on the table who has an acute ischemic stroke. So
Sure.
what do you do for an acute ischemic stroke? You will do that.
Yes, sir.
You can do a thrombectomy.
Yes.
You can do a thromboaspiration. You can do a solimbra.
And what are the chances for new onset stroke, sir, post carotid artery stenting and angioplasty?
Or with a distal embolic protection, you don't get them. Less than 1%.
Sir.
As corolateral, we will be doing the That's a good cerebral circulation. We will take a better picture if the patient gets cooperated at the end of it after removal. That's also important. Mag, can I have the retriever? So this is how we do. Now we have done a carotid artery stenting with the distal embolic protection. We have looked at the cerebral circulation, which looks perfectly all right. Now we will remove the nav 6 and we will look at the cerebral circulation. If everything looks okay, wait for about 5 to 10 minutes and then final angiogram will come out. So capturing the filter is a very important step. You should ensure that the filter is just have some sufficient distance away from the stent, otherwise the filter can be caught in the stent, which will be again difficult. And you can do a partial capture of the filter like has an cap, and then
So you made it look very easy, sir. Now, has there been any incidents of failure to retrieve the embolic protection device? So what does one do, sir?
surgery will be required to do.
Sir.
Then down. All right. Okay. So this is beautiful. Stop. So from this, we have come to this. So looks perfectly okay for us. And look at the cerebral circulation now. Here, please. Patient is doing absolutely fine. This is beautiful. Epipenia. Excellent. So beautiful recognition. We will see the stent in the second and stop. Okay. All right. All right. Mag. All right. This is perfect. So now we finished the procedure. This was a carotid artery stenting with the distal embolic protection, and we have removed the filter. We have looked at the carotid from multiple angles, which looks perfectly beautiful, and we looked at the cerebral circulation, which looks perfectly all right. So we are going to stop here. Thank you very much for your attention. And let me introduce our teammate. This is Parvati, and this is Gauri. He is Prasad, and Dr. Arvind, the vascular specialist, and Murli, the man behind everything. So, thank you very much. Thank you. It was nice spending some time with you all. Thank you very much.